but could have been if it was a tricky question. I get tricked.
Yeah, sometimes like you assume it's an 8-hour.
Oh, the one that had a total of 10 hours.
Mhm.
I think I did that right. I converted it.
Okay.
Yeah.
We can get extra points.
This is.
Yeah, I think I'll end up.
I got.
I didn't know that we were getting bonus points for checks, so I only did like 2 of them.
And
So I'm gonna end up
other
retaking
people
it.
got this as their
Oh,
first too, so I assume that.
I hear it's the same exam.
They use normal.
Hope so. Otherwise, I don't want to do worse.
Right, they did use a normal
Yeah.
distribution. But
Oh my God.
I think even though they didn't know the population standard deviation, the fact that it said the population standard deviation is equal to the sample, then use Z scores or
Yeah.
it ended up being Z scores instead of Z. And that was Ruba's line of thought. That's right. Well, I think we can.
Can I ask you a really dumb question?
Hmm.
I once knew how to pronounce your name, and then I hear people pronounce your name various different ways.
Can I
Is
just
it
take a picture?
Here we
Thalia
go.
or Thalia?
Yeah, go ahead.
It's Thalia.
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 Thank you.
Just in case you don't remember,
Oh my gosh.
Thalia.
Thalia.
You dumb idiot.
Well, I'm not gonna tell you who it was. Thank you. I'm not gonna tell you who it was, but I mentioned to someone that, yeah, Thalia's presenting. And then,
Was it
Thalia?
Joe?
Nope,
Okay.
it was not Joe, and I'm not gonna rat out who it was,
Okay.
but someone corrected me incorrectly. And so now here we are, having this conversation when everything was fine.
For not like correcting people sometimes.
By the way, you're not a dummy. I was talking to myself.
Oh, no.
in that video because I forgot.
No, I haven't done it yet, so.
Well, welcome to the club, I guess. I mispronounced it enough times that I had to make a video.
I'm okay.
Oh, that was you?
Yeah.
Oh, that was a clip from some TV show or something.
Just some TV show pronouncing her name correctly.
Yeah, yeah.
I'm like the only person that pronounces it like that, I think.
You're the only one I've ever met.
I've met several Thalias.
How are you doing?
Yeah.
I've known a few T-dogs. I don't know any. Believe
My
it.
trainer called me T.
I've got a
because
few
she
complaints.
struggles.
Let's hear
Like,
it.
I'm not gonna air
there's another video.
What do you train?
Like, strength training.
Oh, nice. I need to get back into that.
Me too.
It's the diet that's the problem for me,
Yes.
right?
I started intermittent fasting again.
Have you?
Yeah, I'm like fitting in my clothes again, thank God.
Nice. So there's a place called MD Weight Loss Clinic on State Street, and they provide like Mounjaro and semaglutide you can
Oh my
get.
God.
Yeah, well, they have a doctor there. Anyways, I've been on it before. I lost a lot of weight on it, but every time I come off it, I gain the weight again. So I'm going down there after stats. I'm gonna pick up some more, and then I'm just gonna. So,
Exactly.
you know, it works, right?
Exactly. I was on it for 2.5 years.
Keto?
Mhm.
It's so great. It makes me feel like,
Then I slept. Yep.
yeah.
Yeah.
What?
Yeah.
How quick?
Yeah. Took like 6.
That's how I am. Just that same exact way.
It sucks, but it's okay. Like, it's, I gained weight when I moved this.
The ambient air pressure here, plus sea level, it's.
Sugar. It's like at work. I'd be pressured into eating donuts.
Mm.
Donut?
Mm.
There's some candy. I have like a work friend that like.
I forgot my card.
Once a week. And I'm like, stop giving me trouble. And I can't, I'm not always there, so I just find it, I'm like, I love it, right? I need to stop eating. I didn't eat candy before I moved here. I didn't eat candy in like 8 years.
And then you got to Utah and you're like.
I eat candy like but and I used to work out like every day. Yeah. So.
Well, you got a lot going on. This is a graduate program. You took a lot of your time. Plus, you probably got family stuff. I'll say this.
Mhm.
The gym upstairs is really great.
How do you, I'm gonna look for it. I wanna try it.
It's on the second floor. Come out of the elevators, it's on the left. Me and Merida used to go there every morning and then Merida stopped going and then I went on vacation and I stopped going. But it's great. It's small, but there's usually not a ton of people in there, so you can get, and it has everything.
Yeah, I've been wanting to go to and I just never grabbed my bag. It's in my car. Go upstairs, grab the bag. Next semester for sure.
I'm the same way. Next semester, I'll figure that out. Next semester will come and I'll be like, oh, I got too much beginning semester stuff to do.
You know what I've been doing? I just started doing this week to help me because I was like, I got everything. Together. So I started doing pomodoro. Just it needs tomato. It is just like we do 40 minutes of straight study, then you do 5 or 15-minute breaks. Then you go back and just it's like scheduled breaks and then you don't feel it as grad. So in those 15-minute breaks, I would do
Like running place or what?
no, I just do a YouTube video. 30 minutes of exercise on Sunday. I got my exercise and then did my study. I hope with retention, I guess, because they did well on exam. And did you get an email for a product savings?
Yeah,
That weird one?
yeah, I think this is some other thing to grade it.
That
Mentioned he wanted to scan all our exam papers.
makes sense.
Yeah.
That's weird. Why?
Is he using AI?
Possibly.
I'm quite surprised that he wanted us to do like a pen and paper because usually our assignment he doesn't want us done in written form.
Which one I stuff on? Or you just need to do it quickly?
The food is here. Yeah, asking about, yeah, it's here. I heard them talking about.
No, I actually. About good solution
I
sometimes.
still have a feeling it is
I don't
the
think
use.
this is doing what it needs to do.
You know, because it says here, if you assume that X is normally distributed, so if the calcium deficiency in the population is normally distributed, then
Still give me all the same.
you use this T distribution, you do not have the sample standard deviation.
That's the-
Yeah, that's why she said, that's why in that thing, it says that standard deviation equals to S. The S is actually the standard
I could
deviation.
use a lot of.
Food is almost ready. I'm gonna be starting a couple minutes late.
No worries.
Let's,
Okay, let's.
give it 2 minutes and
Very different
Fish
than
up food.
maybe I was.
What he said?
Yours was like 2.45%. Yours is like 9.
Definition.
When I did it originally, I know, I like the, when I did it originally, it was like 1.2%.
Yeah, yeah.
But I changed it because everybody else was different.
Yeah. Collective. We'll get through.
I was probably closer then.
Yes.
We'll talk about that later. Right, today, I appreciate it.
Oh, doctors. With this quote. Just thanks again. It's meaningful, but it's brief. Because it implies not only his Romco done something good once, but multiple times. And that's a track. That's a track record. Trust. That's a track record. Protocols. Should be okay. Environmental medicine. Well, so their impact factor is about double. It's a lot. Looks like.
Can put it as a sign, like you can put it in the same.
I have a consort. Consort diagram. There's a bit of a line. I hope so.
If I don't do that. Brother, how are you? Come over here. You've been here the whole time, haven't you? Well, I wanted to say, I mean, maybe when I see that email, it may have sounded like I was signing you. Oh, no. Okay. Good. I was like, did you sign me up? I signed me up. I wasn't implying.
No, I was more saying.
Oh, me, like.
No, I was more saying, I actually checked your stuff. Make sure.
Right. Thursday.
I wouldn't have thought it's higher risk. That makes sense. That's the period. Yeah, it's good too.
Dr. Rogers. Anyway, I don't feel like I should miss that.
Yeah, it's like, yeah. No one's time was wasted, no one was affected.
Better. Bye.
No, okay,
Mubo, we're trying to give it another couple minutes for people to file in. Yeah. Yeah, that's totally fine. But obviously, I don't know if anyone.
Or she's overwhelmed and burnt out because she has a ton of patients.
It's a
You're so
different-
lucky. I always.
Ian is not. The microphones, they were worked on over the summer. They're working a lot better now, so like, I don't know if you ever attend our office, but it works better now. So it should not be a problem. But that should pick you up pretty good.
Close though.
Oh, it's just like.
You guys get it done?
Oh, yeah, either. I just sent it, I sent it this morning at 6 AM. I go with that. I'll just do it. I'm just taking it.
What did you get on freeze?
I have a big 19.5.
You mind me having that?
Yeah.
See, that's right.
Everything said on the chat, but like.
I use judge.
Break a leg. Don't break a leg.
Yeah.
This. Probably not.
Mubo, I think in 1 minute we're gonna go. Then I'll close the door so it's quiet.
Yeah.
30 minutes to better.
That's the. What's your numbers? Yeah. Yeah.
All right, we're gonna go ahead and Mubo, you can take it away.
And I picked the topic barriers to recovery for medical professionals, assessing financial support through the survey of patient health. There's no specific reason why I picked this. It's just directly related to my current research. And it was just easy to pick something from my reference list. So for the AI component of my study, I created this image through ChatGPT. And I just asked it to give me an image that depicts financial strain when it comes to participating in the physician health program. Two images. For a brief background, the physician health program is a confidential resource for physicians and other healthcare workers. And these are particularly for people suffering from impairing conditions. Impairments, as defined by the physician health program, are addictive, psychiatric, or behavioral issues that group could be experiencing. And the physician health program sees themselves as having a dual mission. So the first thing they do is to assist healthcare workers in their rehabilitation of mostly SUD. And then the second thing they do is to safeguard public safety. So they reduce public health problems caused by impaired healthcare workers through detection, treatment, and monitoring. So I'll just give a brief overview of how it works. So if someone is referred to the PHP, it could be like self-referral, hey, I have a problem and I need help. Or it could be referred through their employer or the hospital board. The PHP then conducts a comprehensive assessment. The assessment is done. The PHP then recommends a treatment plan. So the physician health program is not a treatment center. It's just in charge. Like recommendations. The PHP can potentially. So in this situation could be lose their license and they could have like a revocation of their license, or the physicians can still continue to practice, but could limit their prescription. That's it, for example. If they continue treatment, they finish the treatment, come back to the determine when that physician. So the financial implications of participating in it's a bit complicated because the length of monitoring in the physician health program is about 5 years. And within those 5 years, in most cases, people are not allowed to work. And of course, it also depends on the type of treatment. So there's a combination of maybe inpatient treatment or outpatient, or if you have to do 12 steps or do any kind of courses, right? Cost of the treatment. And then coupled with the work restrictions. So you have people having depleted finances because of the high cost of participating in these treatments. There's a study that measured the average cost, and it was about $5,000 to $40,000 per person for participating in the physician health program. So the study aim was to assess the financial barriers that health professionals face in the PHP. And the methods they used was a cross-sectional study. So the way it works, the author sent the link for the, what's it called now, the survey to the federal body. So like there's a federal body that governs all the physician health programs within the United States. So they sent that email to the director of the federal program, and then the director sent the email to every program manager. There are currently about 50 physician health programs across the United States. And the time frame for this study was between January and April of 2021, so it's pretty recent. So the key survey areas covered the longevity of the PHP, the population served, and then they had like 3 constructs for finances, which included like the ability to pay for services, the assessment of the financial stability, and then resources that healthcare workers have for paying for this program. The characteristics of the PHP centers were, so the PHPs were established in a range of 1974 and 2010. I think some of them were established in the 80s. And then the directors in the program, 45 of them affiliated to the FSPHP, which is the federal body, and then 5 of them were not. They received responses from only 40 out of the 50 centers, which is quite impressive as well. For the clients served in the PHPs that responded to this study, all 40 of them monitored physicians in training. All of them also monitored physicians who have completed training. Only 35 monitored retired physicians, 34 monitored other healthcare professionals, and then 31 did medical students. So for the results, I don't think there's anything surprising here because financial strain really would depend on your career stage. So the results show that medical students had the most strain, and it was followed by the residents. Obviously, like for the medical students, most of them don't earn or they don't earn enough. And the residents would have like student loans and things like that, and balancing that with family, you know, and coupled with the fact that they don't work at that point in time when they're participating in the PHP. So there's a lot of strain on them. So the attendings had lower financial strain, but this is not to say that they didn't have any strain at all, because they're also not working. And then some of them are suffering from the impacts of their addiction because substance use is very expensive, you know. So some of them are broke, you know, and they're not able to pay for the treatment regardless of their status. So for the internal resources that the PHP program managers said they had, we have, some people said they had fee deferral services. About 14 of them said they slide fees, had fee forgiveness programs. This is not confirmed. This is just what they said. And you can see the numbers are so small. This is 16 out of 40 centers. So it's very inconsistent, for example. So for the external sources of support, 28 program directors said there are participants who have insurance providers covering the cost of their treatment. That is 18 program directors that said treatment programs cover this cost. 15 for hospitals, 3 offices of worship, non-profit organizations, and then the list being State Medical Association. And I think that one was for the medical students. So they were able to pay the bill for treatment and monitoring for that one person. So this chart was basically trying to explain the basic financial strain for participating in treatment and then participating in one, rather than 2 separate components. So you can see sometimes, most of the time, always, it's dominating all the charts. So definitely like financial strain is great. So like people, if you're not able to pay for this treatment, you won't be able to actually monitoring. And the longer it takes you to go through this process, the longer it takes for them to return to work, because their licenses are pretty much seized at the point where they're in the physician health program. So it creates a lot of problems for the participants. So the key takeaways from this study is medical students and early career physicians face the greatest financial challenges due to lower or no income, limited social support, and high student debt. They didn't make any mention of the other healthcare professionals, so I'm not sure where they land, you know, if it's at par with medical students or at par with the other residents, so I'm not very sure. And the study also showed that programs that offered financial aid reported increased engagement, improved well-being, and better outcomes for the participants in general. In conclusion, financial barriers are a significant health issue for health workers seeking recovery through the physician health program, but it was particular to those in early years of their careers. And of course, as noted, there are some support systems internally and externally, but none of them are consistent, and we're not able to determine how sufficient they are in helping these participants. So the strengths of the study, I think he had very comprehensive data because they collected information from 40 physician health programs that represent about 38 states in America. So I think that they had a very broad geographical coverage, and the study also focuses on financial barriers. This is also important because most of the studies I've seen around the PHP mostly talks about how effective they are or what their structure is or things they can do to improve them. But nobody really talks about the cost of actually participating in the study. And this was the first one. You can see how expensive the program is. And the study was one of the studies that didn't just say, hey, there's this problem, that problem. They also gave like practical recommendations at the end. So I thought that was also good. But the limitations, my biggest problem with this study was that they used the program directors. Like, these people are not in the program. If you need to get information about how the financial strains in participating with this program, then you should ask the participants because they would know better. And I also think that, of course, we're relying on self-reported data. There could be inaccuracies in the information the program directors provide, because I think some of them might give responses to make their programs look good, which is not great, you know. And I was also hoping to see like an analysis on the different states, because I'm thinking somebody who is doing a rehabilitation program in Boston would spend more money than somebody doing the rehabilitation program in Utah, because those two states have different cost of living. So it would have been nice to see what different states define as financial strain, and then also see what variability exists between the different states. Oh, sorry. So the discussion, I have two questions there. The first one is, should there be standardized financial aids for all healthcare workers across PHPs in the country, or do you think it should be state dependent? I definitely think it should be state dependent. Different states definitely have different standards. Definitely. Yeah. Okay. So the second question is, can the PhD model be adapted to the education sector to manage faculty, staff, and students with SUD?
I think yes, because they have a lot of similarities, like financial strain. Yeah, like I think they're comparative to each other as far as what you know, definitely model.
Possibly, but the problem is, I think for people in education, there's no incentive for returning to work compared to like the physicians. So the physicians need to get their license back. I don't think there's a license to teach.
Yeah, there is.
There is?
Yeah.
Oh, interesting. Okay,
It's not a license to be a student, right? I was interpreting this as the student part of it. Is there? No. Separate yes, no question.
So going back to your first question, I just need a few seconds to wrap my head around it. So I apologize for not answering or talking about it. But you know, I think I agree with what you suggested. I think it should be state dependent. But I wonder to what degree a requirement that there be a financial aid, that there be something in every state could be a federal thing. So federal could say every state must have a financial, an aid program for this group of folks, right? But then say, but that can be state dependent, right? Because if they start putting cut values like, oh, it has to be $50,000, if they start doing that, that doesn't make sense because as you said earlier, Boston's a very different, cost point than, I don't know, Wichita, right? It's just
Wichita's bad.
No, it's just a different environment, different expectations, different cost point, right, for services, etc. So those are the things. I think that makes sense. I did have a question. You mentioned that you wish they had asked like the the participants in the program, not the directors, right? And so I guess the question, not just for you, but just for the group. So what should drive who you should ask the questions to? What should be your where is the decision point there in terms of who you should contact to answer your question?
Depends on your desired outcome.
Yeah. It depends on what do you want to know, right? And so if your question is, what's the experience of this program? Right, the best people to answer that would be the people in the program, right? But if your question is, what are the costs, or what are specific questions about managing or running the program? Obviously, the directors are going to be a better choice. So I think the issue here is they had questions that were kind of hitting both of those, right? And so they had two different, because they had two different questions, they weren't asking, in my opinion, they weren't asking the right person for the specific these different kinds of questions. And maybe they could have been snowballed from the director to program participants. Have them fill out this part, or this survey, and you fill out this one. Things to think about.
Point of clarification for me, did I hear you say the average length of this program is 5 years?
Yes, that's correct.
I see. Yeah, was there any discussion about why that is, or any efforts to? So it seems like a big number for substance abuse, for some of these other things. 5 years seems like a long time to be out of work and dealing with this.
Yeah, I'm not sure why it's 5 years.
Yeah,
it's not in all cases where everyone has to do 5 years. So 5 years is like the maximum.
It's the maximum.
Depends on,
Did you say it's the maximum?
yes.
I see.
Well, not maximum. It's average.
I see.
Let me use the right terminology. It's average. So it depends on the level of addiction. So if you're comparing person A, he had a bad day, drank too much, he got caught, versus person B, that is an alcoholic. You wouldn't give person A 5 years monitoring over 1 day, but you still do some sort of monitoring. Well, I get what you're saying. Yes, 5 years is a lot, but you need to ensure that there's no lapse or relapse.
After a couple of years, you'd think they would be ejected from the program. I mean, a lot of money. A lot of financial resources.
But then the cost of having like that for the hospital, legal issues that come up than one person receiving salary.
Anything else? One thing I'd like to note on this paper is this is a solid journal, and this paper had nothing more sophisticated than descriptive statistics in it. And I think that especially people who are fresh out of graduate school, I'm talking about myself here, are just like shooting for fancy methods. But if you've got really unique data that addresses questions that aren't addressed in the rest of the literature, you can do stuff like this, and there's an audience for it.
Yeah, it's the first of its time, so I think it's.
I might have more of a comment than a question, but as you know, in our class, we recently reviewed the workers' compensation system and how it's a safety net for workers who are injured. People receive 60% of their compensation. They are not able to work, and there are systems in place to help them return to work. And I just wonder, I think there are data to make the case that burnout and stress are associated with certain occupations more than others. Those are also associated with addiction, treatment, recovery. Should there be a system, and maybe it is state dependent for supporting partial wages for people recovering from addiction.
Never seen for this group that are you working under supervision, you have restrictions in your work, or you're not working. Yeah, it makes sense to get someone because it's a long time to help.
I think I read a phrase, the stakes are high for physicians and physicians in training. But for a low-wage worker who loses all of their wages and is dealing with the treatment for addiction recovery and trying to get back into the workplace. Those rates are important. Yeah, just a question.
Anything else?
Since we have some more time. These patients are the ones paying, right? I think if the onus was on the state, or if the onus, if the payment responsibility was on the state or on the organization, I'm still hung up on the 5 years. I'm thinking, if the payment was made by the state or by the organization, I can't imagine it going for 5 years. I think these companies, these PHP companies, are definitely taking advantage of people that are struggling.
Maybe they're not by themselves. They work in line with the medical board. So if the medical board is saying, hey, you have to do this for 5 years, and you can see that there's some hospitals that could be for this treatment. And again, these are comments from the program directors. We don't know if some hospitals pay for some treatment for some patients. The participants will be able to tell us that information if the study was done the other way around. So it's very hard to say. But yeah, these are not actually very aware of.
When the physicians kind of like giving up through this process?
Oh yeah. Yes. So some of them commit suicide. I did one last year and it was very high suicide. And then people just voluntarily retired. Only like 50%.
I imagine it being really discouraging. We have to go through all of this and then still.
You can still practice it. But it's just it's never the same. Thalia Garcia. For those of you. I'm a second year OIP student and I'm doing this because we went over it in class and really there was study 1 or harvest 1 and this is study 2. So I wanted to see if there was an first season study. Now I want to quickly go over a video of her cutting branch sugar cane. The study took place in Nicaragua at the Ingenio San Antonio Sugar Mill. And this place has has an island where the workers live. It's called Island of Widows. So what was going on is they didn't know why there was chronic kidney disease and people were dying in large amounts around Mesoamerica. So they started looking into this and thought, let's implement some interventions. What could possibly be causing this? And they implemented some heat stress interventions and they saw an improvement in the first study. And so they thought, let's improve upon that with this study. So they're planning on a harvest 3, but the harvest period is from November through April. And as you may know, in April 2018, there was civil unrest in Nicaragua. So there is a little bit of that potential effect here. And during the harvest period, it's hot and humid, and the median wet bulb temperature is 86 Fahrenheit around 10 a.m. Around 2 p.m., it's about 88. So that's between medium and high risk of heat-related illness right there. And these are pictures from the actual sugar mill, and they're the only ones I can find. So there were 4 job roles that they looked at: the burned cane sugar cutters, the seed cutters, the field support staff, and irrigation repair workers. And how they recruited them was the sugar mill has pre-employment screening the month before the harvest starts. So they talked to them then, and they, the largest percentage of workers are in the irrigation repair group. So they only recruited about half of those workers. And then almost all of the workers that were chosen were recruited for the burn cane cutters, field support. So the employers set inclusion criteria for hiring, which also is the inclusion criteria for the city. Males had to have a serum creatinine level below 1.3 or uric acid below 7. Females, it was 1 or uric acid 5. And then if they had renal illnesses or diseases, some sort of renal concern or issue, they were excluded, as well as people with uncontrolled diabetes or uncontrolled hypertension. And there were maybe 3 people with potential diabetes and a couple with hypertension, but I'm assuming they were. They provided a questionnaire to the workers on paper on demographics, medical history, if they had symptoms in the prior 2 weeks that could be confounding this, and then their weight, height, blood pressure, and heart rate. And they measured this at baseline and at the end of harvest. So in November and then if workers left during the harvest, they were, the research team went to their homes to try to get information. Why did you leave? Try to address the healthy worker. So incident kidney injury is defined as a serum creatinine increase by 1.5 times from baseline to end of harvest. They didn't explain super well how they monitored, but the employer does monitor their serum creatinine levels throughout the harvest season. And here are some workers seed cutting. So in the first video you saw they cut the leafy part, and so they're cutting up the sugar cane seed, and that's kind of what that would look like. And their intervention was on rest, water, and shade together. So in the first study, they implemented rest schedules, and we'll look at a table comparing the different recommendations and observations of rest schedules. And on harvest 2, they increased the amount of rest time by 20 minutes for all the jobs, and they increased the amount of shade. So they put out more shade tents, and they would rotate these shade tents as the sun changed position. And they moved the tents to be more dispersed, so that they had equal. And so it wouldn't be, 20 workers in one, but could be 6 to 8, I think was ideal. And the rest schedule, differed per job role, so the people with the, more, strenuous jobs had a little bit longer rest time, maybe an additional rest time. And for hydration, they had bolis, which are sugar and electrolytes. And traditionally, from what I know about bolis, they're frozen. The paper mentions they're in a cooler, so it's unknown whether they were meant to be frozen and just the heat kept it split, and so they drank it. So a little on that later, but the workers did give feedback on the flavors they liked, so the people would actually drink it. There were water stations on buses and in each shade tent and where they would clock in for work. And the cutters, so the seed cutters and the burn cane cutters were given lunch and a fresco, which is fruit juice with sugar. There's just extra help there. And they tried to limit the non-steroidal anti-inflammatory drug use. So here's the rest schedule, and there were 2 points that the cane cutters didn't adhere to the rest schedule. So under 8 AM, you could see the study recommended 15 minutes of rest period at 8, and they were observed to only do 10. And then at 10 AM, they also were observed to do 20, and they did. That's something to note, and everyone else was compliant. There was only one time where compliance was measured, and each job was measured at least once. And this was done in March 2019. So for the statistical analysis, the study did a mixed linear regression model for estimating glomerular filtration rate. And because measuring it directly is difficult to do, and they needed something to estimate it with. And they were able to also analyze the repeated measures from the same workers. So a lot of these workers worked there every season. And I think the average number of prior seasons that the burned sugarcane cutters had was 8. So they'd been there 8 times before that, 8 years before. So these are populations that are acclimated pretty well to this job. And they did a 0 inflated Poisson regression for the number of bolis. So the ZIP or ZIP is something you use when you want to analyze a lot of 0 values. So there's a number of people that didn't drink any bolis. So on that, remember I said that it's something usually frozen. So I wonder if that was just something that influenced that and it wasn't addressed to the paper. They also did a cross-harvest trend between harvest 1 and harvest 2 to assess the changes in the estimated GFR. And statistical significance was set at 95% confidence intervals and a p-value of 0.5. So the results, about 20% was, there's a 20% dropout rate. 78% of people completed the entire intervention and were measured before harvest and at end of harvest. And out of the 427 workers at harvest 1, 204 also completed harvest 2. So there's some pretty good comparison there. And then comparing between harvests, irrigation repair workers drank 1.6 times more water than in harvest 1. Seed cutters drank almost 3 times as much, and burn cane cutters drank twice as much. And most people stayed within the same role they did prior season. And the statistically significant findings were burned cane cutters had a risk ratio of 0.2, and there was an improvement in this compared to ours. You can see this table. There was a change in cross-harvest trend for the burned cane cutters that was statistically significant. There was a 6-point improvement. then maybe a resident or someone can help me explain that a little bit better. So some of the limitations of this study were that there was civil unrest in Nicaragua since the end of Harvest 1. So this was ongoing into Harvest 2. The bus schedule changed where they would pick up workers from their towns. So that did eliminate some people that were in Harvest 1 coming back to Harvest 2 if their bus schedule or their bus stop was eliminated. And there was no discussion on whether workers perceived participating in the study as a condition of employment. You could say they thought like, I gotta do this or I won't get my job. And they had to get their blood drawn and need a cuff and go do this before, go do that, answer some questionnaires. And the conflict of interest for me was surprising. It was confusing to me. It's unclear how they're being funded, in my opinion. I think the mill was loaned money by the overarching fund or the overarching study organizing this. And so they loan the money to the mill is paying for half of the study, and then the mill directly pays the researchers. So it's kind of confusing, unclear. So I gave it a score of 5.5, and I asked AI, what do you think? And it said, it's a 6. So that was interesting. I don't know how much I trusted, and I think I was probably so do we have any questions so far?
You know how the cane cutters in particular, but like all of the occupations they looked at, do you know how they were paid? Okay, because just seeing the non-compliance among the burnt cane cutters, I'm like, I bet you they're paid piece rates.
Yep.
They don't talk about any incentives or anything. That was something else to be going.
I'm wondering, would it have been a more effective intervention to just buy new mechanical harvesters? Because the paper mentions mechanical harvesting once, and it's that the machines broke down and it caused a rushed hiring of additional manual laborers. So, not being an economist, I'm just curious, why are these farms not using mechanical harvesters? And to me, I tried to look up the cost. My guess is all the expense on these worker supporting programs could be invested in machines that would remove the risk of the exposure. Then there's also the complex economics of then the workers may not have as many job opportunities, and that may do more community harm than, yeah.
And these cutters they've been doing this for years. The average is 8 prior seasons.
And from the employer's perspective too, like big expensive machinery is a fixed capital cost, and they bear the risk of maintaining and owning that. And it seems like they were burnt, so now they're kind of hesitant. But yeah, if you could just hire workers, then you're kind of offloading that burden in the form of this kind of injury and illness risk onto them rather than.
Yeah, it spreads, the human costs are spread out over time and they're diffused. The capital expense is big and it's immediate. So I guess if you don't have a lot of capital money to spend on capital investments, then you can spend small amounts continually on the worker focused interventions.
On Alibaba, you can get a cane harvester, commercial cane harvester for $12,000.
Curious, when they reported like their breaks, was it self-reported or were they supervised? Because I know a lot of laborers who, because fear of losing their job, will skip breaks but report that they take it. So I'm wondering if it's self-reported or if they were actually supervised, like seeing doing these.
So they had field supervisors that were supposed to be in charge of enforcing these rest breaks and make sure you drink water, change the tent, all that. But I think they only checked it once in March, and that's that chart.
So I don't think there was, besides the questionnaire at the beginning, at the end, maybe they touched on it. Did you adhere to the break and the rest schedule? Or doing it because you think you need to do it for your job, you're gonna say, oh yeah, I did. I thought I saw a hand over here.
I think you did a really nice job presenting a very complex study. I'm gonna go back to the money though. If I'm hearing a hypothesis that you put 8 piece rate, and then basically the way the study was conducted was to buy the owners, managers' attention, time, and effort. Despite this being positive findings and that sort of thing, what can we do about it? What's the applicability? Is it even able to be actioned upon? I'm seeing problems connecting the dots because if it's back to piece rate, it's like, well, you know, the worker's gonna say, no, I'm not gonna take a break. Whack, whack, whack.
Good point.
I think compounding that challenge is the fact that kidney function is generally a more chronic thing versus an acute thing, right? If they were having heat stroke and having, you know, tremendous headaches and being laid up immediately, they would be more likely for their own just function versus the fact that, well, it's just this chronic kidney aspect that it's years down the road. I mean, to me, it equates getting people to stop smoking, right? The outcomes are so relatively remote compared to the immediate satisfaction, gratification, whatever it is, that it's harder to get people to just even contemplate stopping smoking, you know?
Okay, so we went over kind of what some of our concerns were. Was there anything that was done well in the study? Your opinion?
I think there's an opportunity to educate the workers. Whether or not that was utilized, I think there's an opportunity to educate the workers on what's happening and the damages that are being caused.
I haven't directly worked on international agricultural safety studies, but just the sheer logistics of getting a study like this done are super impressive. Like, so, you know, whatever limitations there may be, it's an impressive accomplishment to do a study like this in the field.
Piling on with a participation rate that's a decent participation rate, 78%. Thumbs up.
That's why I think there's, you know, I think I have to do this. Because it was, you know, only 20% dropped out.
Yeah, only 2% like kind of didn't consent to getting the tests done. And in the back, it does say that participant consent was not required for publication, which doesn't necessarily mean they didn't consent to participants, but it does not look as though there was necessarily a consent process described in the methods, which, you know, as someone being asked, oh, will you also participate in the study if I'm going there to be hired for a job? And part of it is, oh, will you participate in the study? I would feel kind of more coerced almost to be involved in the study and participate fully.
I think a strength is piling on to just not only the fact that they got this done, but addressing this population. I think oftentimes agricultural worker populations are overlooked and taken for granted when there really are many different hazards that they face on a daily basis that I just don't even, you know, many of us don't even think about.
And on that, how could this be applied to other occupations? The agricultural workers. Do we need more information to understand the relationship between renal health and agricultural workers? Is this too biased that we just need to redesign something and again, what do you guys think?
I think there are many other agricultural workers doing manual harvesting tasks in the heat all over the globe, so whatever the findings are for, you know, the best schedule of breaks and hydration and all of the guidelines should have broad applicability. Then it's up to, can a state or a country leverage their health and safety systems to get employers to offer those best practices.
There's something about that, the sugar cane that they're harvesting that is like particularly toxic to the kidneys.
They only looked at whether they had handled pesticides in the past 2 weeks. And in between the harvest. I don't think they addressed that, but they did make sure to recommend, so we don't know what actually happened to us, that they wait 12 hours after burning the sugar cane. And they burn it to draw out the sweetness.
I also wonder about application in the mining industry, particularly in developing countries where conditions could be quite challenging. There's many different types of mining instances where there's reasonably high heat and, you know, brake issues, hydration issues. Obviously, underground mines don't have a shade issue, but otherwise there's a lot of similar challenges.
Charles Coaches talked about that mine they're developing in Arizona. What do you say, 125 degrees or something like that?
And humidity, like through the roof, right?
Yeah.
So
When did they mention it? When they plan intervention, did they include someone from Nicaragua? But when you mentioned it, for example, when if the body, if it's frozen, their favorite drink, they might not seem fine, but if you present something to the worker, if there's something that they are used to drinking, their favorite flavor, if what you want is for them to drink it, if it's something that they're already used to drinking it, it may be more likely for them to do so. Did they mention that? Did they put someone from Nicaragua? No?
I don't know. I don't. Ask them.
So to your question number 2, what can be done to better measure exposure? The people should know. You can measure your internal core temperature with swallowed pills and stuff like that. So there's all kinds of stuff you can do now. That would be a much better metric for exposure. Potentially help discern more subtle changes that are more likely in places like California, which is drier heat but drier air. I comment also on the firefighting side of things. If you burn a field, you're exposed to what? Carcinogens.
Yeah, that was the thing I was thinking about, is like they're focusing on heat and that sort of, and compensating for that. But then you mentioned a couple different times, and I've heard it a few times, like, oh, they're burning these fields, right? Well, are they wearing masks? Are they, what sorts of PPE are they? So is the kidney injury a function of the heat and not being cared for in that way and necessarily as well as it could be? Or is it the carcinogens or the, what, you know, they mentioned, you mentioned briefly about pesticides. Well, what happens when you burn those? And those does that release it into the air or does it not? And so there's a whole bunch of other questions, other exposures that I think I don't know, might have a connection to, you know, kidney related injury or any number of other things as well. So granted, they can't focus on everything, but that was the thing I was just kind of like, huh, there's this other exposure going on here that could be an interesting confound to this kidney injury outcome that they're concerned about. So.
And they do spray them.
Yeah, I mean, they spray the pesticides, right? So.
Firefighters now are supposed to be on air, which means on respirator.
Yeah.
when they do overhaul,
Mhm.
which is the term for what you do at the fire after the fire.
Yep.
They used to not be on air. Now they're all being trained to be on air because they're walking around and all the carcinogens are flying all over the place.
And there's a lot of pressure for them not to wear them. The old timers are like, what's wrong with you? You know, why are you wearing that, you baby? You know, things like that. And that's the kind way of saying it. They use other terms. And so infant, yes, they use infant as opposed to baby. So yeah, so there's that as well, which also, I mean, in relation to this sample, right, there may be similar types of things where maybe they are providing them with a mask to wear when the field's being burned or whatever, but are they choosing to do that, right? So other factors as well. But I have a paper that I wrote on the firefighters respirators during overhaul issue, Kurt, and there's a whole set of factors that keep people from choosing to put those on, and increase their exposure.
How are you gonna get somebody in Nicaragua to wear a respirator in
Right.
those kind of heat and humidity conditions?
Not
Good
gonna
luck.
happen. Fun stuff.
All right, great. Perfect slide, because yes, next week is fall break. No journal club next Friday. You can come here, but you'll be by yourself.
Just send you that paper.
We'll be back 2 weeks from tonight.
Yeah. Oh, enjoy fall.
Relevant, you know.
I do too well on the IH exam, so I don't think I did that well.
Very eager.
Don't always. Vegas is actually my favorite connection because I do.
Of course.
Oakland's pretty. It's like.
Here,